those who have node positive disease who have even up to a 30% risk of recurrence. So we really can do better for those patients. DESTINY-Breast05 was a study looking at the patients with residual disease after neoadjuvant therapy. We know that based on the Catherine trial, our standard of care has been to use T-DM1 in that setting. So we know that the Catherine trial showed us an improvement in disease-free survival as well as overall survival for the patients. And the idea was to see if T-DXd in that setting could even improve upon that. Based on, I think, a few things. One is that we know that there are still certain groups of patients who are at a very high risk of recurrence with residual disease, even despite getting T-DM1. There are certain groups of patients like those who have node positive disease who have even up to a 30% risk of recurrence. So we really can do better for those patients. In addition, we know that the risk of CNS metastasis is something that T-DM1 doesn't seem to really reduce. And given T-DXd's activity in the CNS, that's another question that I think all of us who practice breast cancer are wondering whether that could reduce the risk of CNS metastasis for those patients.
Yeah, especially in the last point you were making, just going back just a little bit, DESTINY-Breast12, which is this open label study looking at patients, many patients with breast cancer metastases in the brain with HER2 positive disease in the metastatic setting, we could see clear activity of the agent in that setting. So I think this hypothesis that it could have an impact in the early stage setting was a sound one as well. You said a couple things, so I just want to unpack a little bit. You said that this trial looked at patients at high risk of recurrence. So in your mind, what is that? Because to me, I'm just thinking anybody that's got residual disease is, quote, at high risk, but we know that's not entirely true. So what does that mean to you?
Right. So I believe for DESTINY-Breast05, it was the patients who were deemed high risk of recurrence based on the fact that they were either inoperable at onset or their residual disease had node positive disease involved. So that's really how they pulled out the high risk patients. So I think it's really important to keep that in mind, that this is for a specific group of patients, because those are the patients we're really worried about recurrence in.
So this is hot off the presses data, like the papers, everything. We're still all processing the presentations on the podium and everything. So have you been able to talk to a patient about this yet?
So I haven't had a patient yet who is in this situation. I have a couple people who just finished their neoadjuvant TCHP and are having surgery this month. And they were both node positive to start with. So I think I will consider it if they have node positive disease.
Persistent disease in the nodes, yeah.
Yeah.